as you're joining us, please complete the poll and tell us a little bit about yourself. We would love to know who's in our audience today and ensure that we are addressing the concerns that are relevant to each of you. So thank you.
Mylynda, are you ready to get started?
I think we are.
All right, can you share your screen?
Yeah. Anna, do we have results from the poll?
Yes.
We have a winner for genetic counselors and genetic counseling students, which is great. We have some family and family advocates present today, some physicians, some non-genetics providers, and those representing public health. So this is great. Thank you for completing the poll. So I'm going to start us off today by introducing myself, and then Alex is going to introduce himself as well. But my name is Dr. Mylynda Massart, and I am a family medicine trained physician at UPMC and faculty at the University of Pittsburgh. And we are going to both be talking, Alex and I, today about scalable models for delivering genomic services. I'm going to be speaking from the family medicine perspective and Alex from the pediatric perspective. And I have one disclosure, as you can see on my slide here, as a scientific advisory board consultant for GRAIL. Alex, do you want to introduce yourself?
Sure, thanks, Mylynda. My name is Alex Whitaker. I am a pediatrician at the University of Maryland, and I work at the University of Maryland Medical Center. And I'm going to be talking about scalable models for delivering genomic services in the pediatrics area. And I do not have any financial disclosures. So we'll start off today by talking about the challenge. There's many challenges in providing genetic services, but the one we want to talk about today is who's providing that care and the time and the patient experience. So the need for genomic services is certainly increasing faster than we can train providers. We'll provide some data about this later, but as we all know, the area is just exploding. And really this is being put on geneticists' shoulders. And sometimes there's just not enough of you. So that can result in sometimes decreased patient satisfaction and care that's not received. So the landscape in general, as we see it, includes all these things. So I'll run down here what geneticists are doing. Providing services relating to primary care, so things like prenatal testing, familial hyperlipidemia, cancer risk assessments, and then there's services related to specialty evaluation, so cardiology, neurology. You can see some examples there, ophthalmology, and back to oncology again. There's the testing embedded, or I should say genetic counselors embedded with specialty or genetic testing utilization clinics, genetic evaluation and management of possible syndromes. This can be in the NICU, for pediatrics, for adults, rare disease clinics and multidisciplinary clinics, the intersection of clinical work and research, so working with industry partners, and support of research. And so what that is doing, as you can see in this graphic, is creating a bottleneck. All these different things, pharmacogenomics, pediatric genetic disorders, specialty genetic testing, metabolic disorders, prenatal genetics, direct-to-consumer genetics, cancer genetics are all going in the same funnel, and creating a bottleneck. And I think that's what we're gonna talk about is some solutions, how we might alleviate that today.
Yeah, thanks, Alex. So in my mind, I really think that one way that helps to break this up and think about it going forward with some solutions is to really think about genetics as a tool versus genetics as a clinical subspecialty, which I call the art of genetics, right? And so historically, that art of genetics has been practiced in medical genetics and is really looking at classical genetic syndromes, diagnosing metabolic genetic conditions and rare disease genetics. And now we are really evolving to an era where genetics, in addition to this, is also becoming a generalizable tool. Looking at things like polygenic risk scores and genetic cancer risk assessment and pharmacogenomics, direct-to-consumer validation testing, carrier screening, diagnostic testing. And now we're really advancing into an era of the clinical exome and probably soon genome as cost goes down. This will also move from subspecialty clinics to the general toolbox as well. And I compare this very similarly to what has happened historically in medicine with radiology as a subspecialty versus radiology as a tool. Radiology as a subspecialty, really includes expert level interpretation and interventional procedures, but radiology as a tool is something that all clinicians can order, and we order routinely standardized diagnostic testing as X-rays, CAT scans, MRIs. Similarly, cardiology as a subspecial, right, includes expert level interpretation and interventional procedures as well. But cardiovascular as a tool, again, all clinicians routinely order standardized diagnostic testing such as EKGs, echoes, and stress tests. So I think, if you really think of genetics in those two categories, then you can start to think about how these services can be delivered across the health system. And then we can flip this model into a new model where instead of filtering everyone to one downstream service and creating that bottleneck, we instead create a triage model and get patients to the appropriate service, to the right level of care for the right clinical question and the right level of expert need. The benefits of providing a triage genomic service across a healthcare system for the patient is really access, right? The time it takes to get to an appointment, cutting down some of that bottleneck. Triaging the patients allows them to see the right level of care for their need. It can be much more cost effective and provides access to cutting edge medicine and diagnostic tools for the patients. On the system side, this really increases patient satisfaction. It allows regional centers of genomic service excellence so that patients can be seen across the system. It allows to be a national clinical implementation leader to really roll out emerging genomic technologies across the span of our clinical services. It balances maximum reimbursement, creates downstream revenue generation, allows for industry partnership, and increased grant funding. In particular, I have built my whole career around integrating genetics into family medicine. And I think this makes a lot of sense for many, many reasons. As a primary care expert, we are really on the front lines. And we take care of these types of conditions routinely, right? We are always thinking about preventative care where risk panels would make sense. We are doing prescription management, so pharmacogenomics is directly relevant. We are doing routine cancer screening, so therefore genetic risk assessment should be integrated as that. We are doing prenatal care and can integrate prenatal carrier risk screening and NIPT. We do newborn care for newborn screening, and of course, chronic disease management, where polygenic risk scores and environmental influences come into play through precision medicine. We also practice lifespan medicine, right? So we are taking care of multi-generational families across the lifespan. We typically have strong relationships and a good understanding of our patients and their families and their biopsychosocial situation. I apologize, I cannot speak this morning. And I think the genetic counselors in the room would say that, that is one of the real critical elements around addressing genetic issues and concerns, is truly having that relationship and that understanding. As we all know, there's been a lot of work looking at the barriers to the integration in genomics in primary care, including lack of knowledge and comfort in genomics, lack of integrated electronic health records, and clinical decision support at the point of care. We have a lack of algorithms for randomized controlled trials and how to integrate this and to create those algorithms. We know testing is very highly nuanced. Insurance coverage is not transparent and is complicated. The technology is advancing rapidly, and I would say that the largest barrier, of course, to integrating in primary care is time. Primary care providers are maxed out already, and it's very hard for them to conceptualize integrating another aspect to their practice. So again, time is so critically important, and the ability to do quality pre and post-test counseling is, I think, a major challenge to integrate into primary care provider practice. One solution for that is we could think about recording genetic counselors with generalized counseling tools that primary care providers could then have readily available to show their patients in the clinic. We also know testing is highly nuanced, and that figuring out the type of test, the insurance coverage, interpreting the results, which can be complex, and will continue to be even more complex in the future as we move more and more towards whole genome sequencing. There may be less nuance around the testing itself, but possibly much more nuance around the results and the interpretation and how we explain that back to the patient. So these are going to be critical challenges moving forward. So what are some of the solutions to overcome these barriers and challenges? So one of the things I like to think of is how can we leverage primary care services to deliver genetic services? And over the course of my career, I have really evolved my thinking in this space to 3 different models. There's the first model is to integrate genetics into what I call the classical primary care model, and I'll explain that further in a minute. The second one is a hub and spoke model of genetic experts serving in primary care. And the third one is a distributive model of seeding genetic counselors across the primary care. So the first one, as I mentioned, is integrating genetics into the classical family medicine model. So family medicine physicians are trained in a very broad scope of practice. And the truth is they really practice up to about 70% of all areas of medicine, right? So pulmonology, cardiology, endocrinology. So could we add genetics into that training and really have family medicine docs integrate this as well, and be able to practice up to that 70% expertise in genetics? Another thing that family medicine doctors are well trained in is once they reach that sort of 70% confidence in a particular subspecialty is when they are kind of at their limit and when to refer to specialty care. So the first question is, can we get family medicine to that 70% confidence level in practicing genetics and genomics? And then how do we educate our current trainees to achieve that goal going forward? And how do we support current practicing physicians to achieve this goal? The strengths of this kind of a model are, as I mentioned before, many genetic issues align very well with primary care topics, including prenatal carrier risk, genetic cancer risk and screening, pharmacogenomic impact on prescribing, complex chronic diseases such as diabetes, cardiovascular disease, et cetera. Another strength is this integrates genetics like all other subspecialty care in family medicine. The challenge, however, or the weakness of this model is that our current medical education lacks adequate genomics training. And so most practicing family medicine physicians feel not even 10% confident in integrating this into their care, let alone 70%. Residencies do not have access to a solid genomics curriculum, so we are continuing to train family medicine doctors without the preparation to take this on in their practice. And practicing physicians are simply overwhelmed and cannot conceive of adding expertise of one more topic to what they're currently managing already in their daily routine. Finally, family medicine still does not recognize that genomics is now and not 5 years down the road from now. So when I go around to primary care conferences and I talk about integrating genetics in primary care with the clinicians, they really still feel that this is in the future, when the truth is the train has actually already left the station. The second model is what I call the hub and spoke model of genetic experts serving primary care. And this is where we would establish primary care genomics experts strategically to serve multiple primary care clinics or a region. And this is actually our current model that we are doing here at UPMC. So again, this is where we would have one primary care clinic with that expertise in genomics or genetics, serving multiple primary care clinics where they could refer over to that specialty center to facilitate any of the genetic services needs that their patients require. The strength of this model is it requires less total number of genomics experts in primary care. It does provide a stopgap while education is catching up to train future clinicians so that there is currently a place for the patients to be seen and to access these services. And it's a great opportunity to teach the referring providers with each and every consult by sending them back detailed information about the patients they referred and the management plans that are recommended, including the testing. The weakness of this particular model is it really is an external visit for patients. There can still be some delay in access to this service because it is one hub serving many, many spokes. It is an unknown provider outside of the medical home, which is a challenge for vulnerable patients. And it feels more like a specialty consult as opposed to embedded in primary care, even if it is a primary care colleague delivering that service. So the third model is a distributive model of seating genetic counselors across the primary care field. The strength of this model is we can definitely educate and scale certified genetic counselors more quickly. We can offload the nuanced pre-test, post-test counseling and test selection interpretation from the clinicians and really have the experts who are trained to do this type of service, delivering this to the patients, but within their primary medical home. There's an existing multidisciplinary model already in primary care where frequently we have pharmacists, social workers, and nutritionists embedded in our practices. So this would be an extension to embed a genetic counselor as well in this multidisciplinary team. And it's a really great opportunity for real-time genomics education to be happening to the clinicians within their practice through the genetic counselors. The weakness of this model, as we all know, is that genetic counselors cannot yet bill independently to support their practice, nor order testing independently either. Although I do hope this is going to change in the very near future. So I do have a poll question to pause for, and I think, yep, there just popped back up. So of these three models that I just described, which model do you think you would see working best for your community or your health system? The classical family medicine model, where the family medicine provider practices 70% of genetics, just like all subspecialty information. The hub and spoke model, where we have one clinic serving many primary care centers, or a distributive model where we integrate genetic counselors into a multidisciplinary team.
Oh, we have about half people who already answered.
Great. I
It
can't
looks
wait
like
to
we
see the
have
results.
yeah, it looks like we have a leader. Maybe let's wait for the other 15 participants left to. And I'm gonna close the poll in 5, 4, 3, 2, and 1. All right. Sharing the results.
Distributive model, awesome. And definitely followed by hub and spoke, and the least favored the classical model. So I think that this is 100% exactly in sync with my own impressions of how we should think about moving forward. I think that it's very possible that the first model, the 70% integration into family medicine, may be impossible, at least for quite a while, until education dramatically catches up. And so I do think then, depending on the community, either the hub and spoke or the distributive model will be more successful moving forward. So we are actually trialing both of those models here at UPMC. We have currently launched a hub and spoke model at UPMC, where we are trying to address the needs of current patients. We are really working on integrating genetics in primary care. What does that look like? Working through several types of challenging cases to see if we can create solutions that could then be disseminated out to other family medicine clinics and providers. We are also working significantly on overall genomics education, so how we can continue to advance the education of primary care providers while we are providing the stopgap service. And then we also serve as a forefront for trialing new and emerging technologies in precision medicine here at UPMC to discover what that looks like and how we might be able, again, to disseminate that out across the healthcare system. So this is our team. We have two incredible genetic counselors, Natasha Berman and Christine Monroe, and my colleague, Dr. Luke Barenbrock, who is our clinical pharmacogenomics expert. We created the clinic to see a diverse array of patients in this hub and spoke model. We knew that there were many patients who were simply early adopters of genetics and precision medicine services who were looking for access to this care, especially in the space of pharmacogenomics, and also how to interpret and validate direct-to-consumer testing that they may have undergone. We also knew that there were both national research studies and local research studies in the Pittsburgh area that were going to be soon returning genetic results back to their research participants, and that patients needed a clinical space to take these results to again, receive more education and plans on how to integrate this into their clinical care. We definitely needed the triage that was mentioned earlier for downstream genetic specialty services to ensure that the patients who truly need the medical genetics subspecialty expert are able to get to that level of care in a timely manner. And then it turned out that here at UPMC, we needed a significant amount of expediting and facilitation of adult genetic testing through utilization management and counseling services. So I'm going to tell you a little bit about this current model that we have at our UPMC Primary Care Precision Medicine Clinic. Our workflow is we start with a genetic counselor intake where family and individual health history and pedigree are obtained and risk assessment is determined. On our pharmacogenomics intake cases, we additionally have our pharmacy team do a medication review and determination of testing recommendations if appropriate. And then I complete a physician intake. I hear from both of the other teams, review the history that was obtained, and complete the exam. We then meet once a week and do a multidisciplinary case review to develop final recommendations for each of our patients. And if testing is recommended, then a subsequent pretest counseling appointment is scheduled between the genetic counselors and the patients, as well as a post-test return of results visit, and then consult note with as much education as possible is completed and sent back to the referring provider. As many of you had to do, we also had to rapidly pivot to a virtual clinic and telehealth in March of 2020. It turned out that this has been a tremendously successful model for our clinic and has expanded our access to even some surrounding states who often use our health system. And especially to increase services to rural areas. It turns out Western Pennsylvania is mostly rural other than just Pittsburgh. So this has really facilitated visit access for many, many, many patients. We also have developed an e-consult process through our electronic health record, which allows providers to send referrals for quick review to triage whether patients need to be seen or not, and can advice be provided to the guided referring provider. So this kind of helps with that triaging filter to the right level of service, whether or not the patient needs an appointment with us or whether they need to be expedited to medical genetics. So this is just a quick summary of some of the types of cases that we have seen and the scope of cases that we have seen since we launched in early 2020. We have ended up filtering 5 cases that most definitely needed to see medical genetics, and through that triaging service expedited those referrals. We have done over 28, probably more now, genetic cancer risk assessment testing, over 70 pharmacogenomic tests. We have done 269 adult testing for subspecialties with genetic counseling and testing facilitation and utilization management. We've had 10 direct-to-consumer cases who have come in requiring education and validation. and 5 prenatal carrier risk screening cases thus far. We have also looked at many translational types of implementation of emerging technologies for the health system, including cell-free DNA screening, whole genome sequencing, and microbiome evaluation. In the future, we are hoping to set up as well a trial of the distributive model that I presented earlier to increase access to genomic services for our underserved population here. And this is to deliver services by embedding a genetic counselor in the medical home of one of our most underserved primary care clinics. We hope this will dramatically reduce barriers such as transportation, digital divide, and trustworthiness issues in seeking out our services from the patients who are referred to us from our primary care network. In addition, we are working on some of the algorithms that I mentioned earlier that need to be developed for primary care. One of them that has actually been a really great and fun project has been around hypermobility spectrum disorder, really looking at this at every different layer from monogenetic conditions, multi-locus conditions, and polygenic risk scores, plus environmental triggers or exposures. And trying to figure out who exactly needs genetic testing, what testing is appropriate and why, what we can do in terms of recommending symptom optimization and management back to the PCPs, and further determining clinical HEDS criteria in particular. We'd really like to get comprehensive management versus high-risk screening back to the primary care providers. On the left side, you can see we have sort of a pie model where some of the most prominent symptoms that hypermobile spectrum disorder patients experience, including POTS and mast cell activation, GERD, irritable bowel syndrome, depression, anxiety, joint and muscle pain, joint laxity, pelvic floor dysfunction, fatigue, and brain fog. You know, all of these are perfectly well suited for family medicine, ongoing chronic management, whereas those who really triage to the high concerns or test positive for one of the monogenetic EDS syndromes may need ongoing vascular aneurysm surveillance, cardiovascular monitoring, ophthalmologic monitoring, organ rupture and prolapse risk, and surgical healing risk management, which again, can actually be co-managed through the primary care provider exceptionally well if given the right support and guidance.
Mylynda, I'm going to ask you to wrap up because we're
running out of time quickly.
Yeah, well, and Alex still has something to say. We have a little extra time because Raylan's session had a little glitch at the beginning, but we want to give Alex at least the next 10 minutes or so. So again, I think the thank you, and obviously the slides are terrific and lots of good things to talk about, but I want to adjust time.
Absolutely. So I'm going to stop here and hand it back to Alex to share more about his clinic experience.
Thanks.
Thank you. And you said I have about 10 minutes?
Yes, thank you, Alex.
Okay. Okay. So I'm going to give another example of a hub and spoke model that Mylynda just talked about, which is what we do at the University of Maryland. And I want to start with a case here. I'm not sure if that went into, that played how I thought it would. There we go. So this is patient BH, infant male born at full term. They failed their newborn hearing screen in the nursery, and some facial differences were noted at their first pediatrician visit. So they were referred to pediatric genetics. They had not yet followed up with audiology at that time for a formal hearing test, so we were a bit unclear of the official diagnosis. But I do have a picture of BH, of the patient at 2 months of age. Just some things to note, a flat nasal bridge, really bright blue eyes that were abnormal for the family, who all had brown eyes. And then you can see a hint of a white forelock there in the front of the scalp. So a question for you all. BH's parent, what barriers do you think they encountered in setting up a genetics appointment? Had trouble finding a clinic, were told there was a long wait time, they were unsure if they wanted testing, or D, all of the above. I think probably most of you know what the answer is here.
Yeah, so we have a very clear front runner. We have about 60 people who already participated. Let's give it a few more seconds. To anybody else who would like to answer the poll. And I'm gonna slowly close the poll in 5, 4, 3, 2, and 1. There we go.
Yes. Right. So the parent was concerned about all of these different issues, and hopefully we can. Mylynda and I have already discussed part of A and B, and I'll talk a little more about that. C, I can't really help too much with that, but that was a concern that Mom did have and that we talked through. Okay, so just to wrap up BH's care, they were seen by myself, general pediatrician, and the genetic counselor 9 days after contacting our department. We did send testing, and the DNA results returned positive for Waardenburg syndrome 13 days after the appointment. And they did have a phone call with our genetic counselor 3 days after diagnosis to discuss what that meant, natural history, and further steps from that point. So this whole process took about 24 days, 3.5 weeks. It was a pretty rapid process, and that's what we're proud of providing. So back to, again, just the general background that we're talking about here, access issues. There just are not enough geneticists. Per the certification exam in 2017, there were 1,583 clinical genetics and genomics specialists, and that equates to approximately 1 per 200,000 people in the US. And at our facility, wait time for appointments can be up to 18 months and sometimes longer. I did find some other clinics in the literature, besides what Mylynda is talking about. There are other ones out there. I found one, a pediatrician practice in Kansas that, again, was a pediatrician and a genetic counselor that helped to decrease wait time to see a geneticist, and patient satisfaction scores were not affected. I'll show you some of our patient satisfaction scores in a bit. An example 2 is a nurse practitioner practice in Missouri. This one was interesting because it did make care available in an underserved area, and they both served adults and children for this clinic. And as I said, both clinics were staffed by genetic counselors to facilitate testing and counseling. So this is a nice little graphic that the nurse practitioner clinic included that, kind of ran down what the roles of the counselor were, what the roles of the nurse practitioner were, or what a pediatrician would be, and then what they did together, which was the family history, the part of the dysmorphology exam, documentation, and creating a client and family-centered approach.
Alex, excuse me, I've just been alerted. We're going to go back to the main room at 10:20, so it looks like you have a little more time. I apologize for.
Sorry, you said I have a little more time?
Yes, you have till 10:20 when we'll go back to when we're going to cut into the break more.
Okay, all right, thank you. So going back to our experience at the University of Maryland, we did start this in 2018, and I have approximately 2 clinics monthly, myself and a genetic counselor. I do want to thank some of our genetic counselors who I know are here. Megan, currently, Stephanie, I believe Rachel is here, Julie. So thank you all for your help. 42 patients we saw in the first 6 months of the pilot period. And the way we triage, I think Mylynda touched on this a little bit, was a counselor would review cases prior to us confirming appointments to ensure that they were appropriate to see a general pediatrician. And patients certainly with complicated metabolic presentations or diagnoses would always see our medical geneticist, Dr. Green, who I'm not sure if she's here as well, but I do want to thank her for recruiting me for this clinic and for all her help. Our clinic flow, so again, similar to what you've heard, the patient's first seen by our genetic counselor who obtains a medical history and a pedigree. And then I go in and perform any additional intake that's needed and most of the physical exam. And then we come back for our combined decision-making and discussion of management and testing. There is a weekly case conference where complex cases are presented and discussed in front of the whole team. And a follow-up appointment can be scheduled with a geneticist if necessary, if decided at this conference, or they can make additional recommendations to myself. So this is a nice little chart that runs down the different diagnoses that, or at least the different complaints that we saw in our first 6 months of running this clinic. We did have trisomy 21, several chromosomal abnormalities, short stature, some minor metabolic conditions such as SCAD, NF1, Beckwith-Wiedemann, several patients with neurocognitive disorders, as well as seizures. The majority of our patients were there for dysmorphic features or congenital anomalies, generally referred by their primary care provider. We did have several Ehlers-Danlos evaluations, and 2 patients fell into the other category. So we did distribute satisfaction surveys at the conclusion of outpatient visits for myself and for Dr. Green, our medical geneticists. We gave them to a random sampling of patients. I was able to get 10 surveys back. Dr. Green was able to get 18 surveys back. The questions that we asked were, did the genetics team address your concerns? Were you given information in a way you could understand? Was a follow-up plan established? Were you given a chance to ask questions? Did you receive something of value from the visit? And what's your overall satisfaction of the visit? And what our results told us was all patients and families surveyed for both myself and the medical geneticist reported the genetics team addressed genetic issues for the child, reported they were given information in a way they could understand, and reported they were given a chance to ask questions. So that was 100% of patients answered yes to that. There was no difference between providers for the question about a follow-up plan being established at the end of the visit, although not all patients answered this question. And there was a small difference between us for patients and families receiving something of value from the visit. So 9 out of 10 for myself and 17 out of 18 for Dr. Green. And this is the main slide I wanted to focus on, just the overall satisfaction with the University of Maryland genetic services. And you can see, I think we got pretty good results here. So of note, across both providers, no one was dissatisfied or very dissatisfied with their care. For myself, 8 out of 10 patients were very satisfied, with the remaining 2 being satisfied. And for Dr. Carol Green, 16 16 families were very satisfied, with the remaining being satisfied or neither dissatisfied or satisfied. So again, no one was dissatisfied with the care that they received from us. And I think that's an important takeaway. So our goals for the future, provide a framework for primary care providers and mid-level providers, such as I mentioned with the nurse practitioner, in genetics clinics to start their own clinics if that were to fit their models. We do want to collect more data about patient access and wait times. The way that we do schedule an EPIC makes this difficult. We're trying to get around that and see if we can quantify how this clinic helps with patient wait times, and continue to provide timely services to our pediatric patients. Those are my references, and thank you very much.
Great, Alex. I think I'm going to say 2 things. One, we have, I think, 2 more minutes here. So one question was there an evaluation satisfaction of the old model, to compare to this data?
Sorry, I missed the first part of the question.
Yes. Was there data from old models or prior satisfaction data to compare to this? Is that very satisfied?
Well, yeah, we not exactly. We used our geneticist, Dr. Green, as kind of the control because her clinic did not change.
I see.
So we compared her clinic, which has been similar all along to mine.
Right. I think, Anna, you may want to check, forgive me, this is again a transition issue with Erica, because my understanding is we went back into the main session. So it may be that we have to go back to the main session. There is a Mentimeter question because we knew there might be a little inequivalence of time. I'll just offer up one comment from the chat before we go back to the main session, because again, I don't know exactly what's gone on in the other session. And that is, there were some questions in the chat for both Mylynda and Alex, I think, around sort of the scariness of genetic testing and families, you know, being prepared for assorted results sort of thing. And that may be a good place, depending on when we get back together with Raylyn. The other question I had thought of starting with back at the next session was, is there anything you are doing currently that you can imagine being replicated quickly, say by December of 2022? So I'm going to leave those. And if you want to transition us back to the main session, which I think we do by leaving, is that correct? Or are you controlling this?
Yes, I'm going to paste the link in the chat and you can follow that link.
So let's leave and have those thought questions in our head as we greet our friends from the other session. So take a look in the chat and leave this session and return to the main session if you would. And thank you both so much for really fascinating and thoughtful talks.
And thank you, someone who's already right on that, sharing what they learned. I'm gonna put the link in chat here. If you're just joining, this is how to participate. What's going on is go ahead and click the link in chat and answer that question. All right, we're seeing answers coming in as Kenzie's opening the door. I think we have people still coming in the front door. I'm going to keep pasting in chat because those of you who are in the session, you see all the stuff happening over and over again in chat. And that's because when you join a new Zoom meeting, when you're just coming back, it's like a clean slate. And so the people who are just joining can't see what was pasted before. All right, Joanne, should I put you up here to speak to what you're seeing coming in? Go ahead and unmute yourself and then I'll be able to hear.
Group is mostly here and really reinforces the themes that our speakers so thoughtfully generated around thinking of new models, working on genetic counseling billing, and really trying to shorten the trajectory from genetics to primary care. And again, I think that's what these models are under this group. Do you have any sense of when the other group is going to be coming in? Are they here?
They're coming right now. I just heard a notification in the back channel.
Yeah, no, I think again, we really, people are so good about, I think, great listening to great speakers here is what we, I'll repeat, the need for genetics in primary care is now as maybe the theme for our session.
Yes.
I think just in the interest of time, I know, how do you want to do this? Do you want to, we're up to 111. I don't remember. I think we were at 119 when we started.
Yep, we can see there's still people coming in the waiting room. Okay. And so just when that slows down, I'll give you a cue. And I'm pasting in chat here so that people who are just joining have a chance to participate in this because they can tell something's going on.
Yeah. And when then, I guess I saw that I was getting different Or I got a couple messages about how long we have now, I guess, till the break.
Yes, we will go to the break in just 5 minutes here.
Okay. All right, well, maybe the folks can be, the speakers can be transitioning again to the question of, you know, what are you doing now that you can see replicated in another center most quickly? And I used December 2022 as a goal for that, but, you know, what would be those quick steps to try to make some of these ideas happen? So that's for Mylynda, Alex, and Raylyn.
Okay, great. Kenzie, can you bring those folks up to the stage if they are in the meeting?
Yes, maybe not all of them are here yet, but we've definitely got at least one.
I got Alex there.
I'm here.
Too.
Oh, hey, Raylyn.
Hi.
And then Mylynda, maybe we can see if we can.
Yes, everyone's here now. Great.
Okay. So again, we have just a few minutes now, and appreciate, you know, what I know was a great talk from Raylyn, and I heard Alex and Mylynda, but I'm going to ask and try to pay attention to the chat. Of all the things you talked about by way of improving access and models and amazing funding and bringing people in and teamwork and collaboration, is there one thing you could say, and I'll say a genetics professional or a family might, you know, have to partner to start this, but what's one thing you're doing that you think could be done this year in another center? And maybe I'll start with you, Alex. I don't know exactly how long it took, you know, Carol to recruit you and train you and all the rest, but you think your model is, you know, reproducible in a center now?
Yeah, I do think so. You know, a lot of the Mylynda went through some of the different models. I do think the hub and spoke model is the easiest to, and that means, you know, outside of the medical home, a separate clinic of a, you know, primary care provider and a genetic counselor together. That kind of model can, the benefit of it is it can be replicated fairly quickly. There wasn't a huge amount of training that I needed beforehand. Most of it I received during my residency. And so that was something that we brought about in a few months, and it has been successful. I think also having the genetic counselors there is really a big part of it, that they're just so knowledgeable and can really have helped me guide me through this process.
Great, thank you, Alex. Mylynda, how about you? If you could choose one thing that's the fastest to replicate, and I mean, obviously in a thoughtful, collaborative way.
Yeah, I think the very first step is to identify a primary care physician champion, whether they have the background or not, as long as they have the passion and the interest, and then in parallel finding those genetic counselors who would be excited to take on this primary care challenge, and partnering those groups together to begin the discussion and investigate how they might be able to launch into creating that hub and spoke model.
Raylyn, can you hear us? Thank you, Mylynda.
Yes, I can.
Great.
So I didn't talk too much. Oh, is my prompt the same?
Well, your prompt is the same, but I was going to say, if you wanted to, because I know your slides, if you wanted to use PKU as an example, because that's certainly one where, again, there is a lot of back and forth with a PCP potentially, but your call on how broad you want to make your response.
Yeah, so I did talk about PK, since you brought it up, I did talk about PKU to our group as kind of the hallmark condition that we have that has been amenable to treatment, and how we've seen treatment evolve. And so I think it is one of the more common conditions too. So I also just talked about kind of this cycle of communication of the PCPs working with the subspecialists. I don't think, you know, PKU in general is a great example, but just in general, people kind of recognizing that there's evolving treatments for various genetic conditions beyond just kind of the ones that we think about in terms of the genetics clinic that we see, but, you know, sickle cell, cystic fibrosis, amyloidosis, some of the neurological conditions like Parkinson's, ALS, are all having evolving therapies. And they're in the news and they're on podcasts. And so to kind of empower our colleagues to check those things out and be excited about those things so they can be part of the team here.
And maybe one last comment I will take from that. Thank you so much. Mylynda, any thoughts ahead on partnerships that involve nutritionists or, folks who can follow up on the pharmacogenomic as it moves to potentially, broader issues, or how you're thinking about expanding the model for other professions where there may be a shortage of people, and yet we need to figure out the distribution of service to make it more accessible for families.
Yeah, so we actually do have a nutritionist who is a part of our team as well. Sorry, there was a lot in that question, so I'm trying to just.
I'm thinking on my feet or somewhere
Yeah.
between my ears. I guess I was asking, I think that the challenge is the individuals who take the most time, in a sense, and almost require a one-on-one precision thing. I don't think any of us entirely have our heads around how that can be in a distributive model. On the other hand, those folks are often closer to home, et cetera, and how we think about, particularly for things where, we're covering almost 1,000 metabolic patients here out of Hopkins. How do we think about those models when we start to add to, as Raylyn has talked about, so many more diseases, so many more therapies, but are there some that could be handled in another way of thinking about collaborative care with primary folks at the center, in a sense, or with another team member?
Yeah, so I think there, right, the key is communication, right, and opening up the lines of communication between the primary care providers and the subspecialty providers, and especially around complex management of these underlying syndromes or metabolic conditions, and really providing some guidelines for primary care. I think, when most of us trained in primary care, we got to something genetic or something metabolic, and we sort of had this reflex to refer. And we need to evolve our thinking beyond that says we can actually co-manage patients, right? And this concept of co-management can give the primary care provider the support they feel like they may need if they have questions or concerns, to be able to reach out to the subspecialist without overburdening the subspecialist to actually be the primary manager of all of these patients. So I think it's that co-management model is really important. I also think that there's a scalability issue here where we need to, Alex and I need to help everyone else recreate these models at other institutions. And I think we'd be very happy if anyone has questions to reach out to us. But one of the things that we're doing here is we just actually launched a training track in our family medicine residency. And so we have our first resident that matched this last year, and he'll be doing his second and third year continuity clinics with us in our precision medicine clinic, to actually start thinking about how can we scale, how can we create more trained providers if we do go with that hub and spoke model. So I think it's the co-management and thinking more about scalability.
And there are not, to my knowledge, family medicine genetics combined residencies. Is that something you see in the future?
Correct. There are not as of yet. I do think that's something we really, really need to think about, is that primary care genetics combined residency, with the intent to get the provider back into that primary care facing space as opposed to subspecialty medical genetics facing space.
In full knowledge that people who need a break should take it, I'm going to continue here for a moment, Erica, and all your independent people. And if you need a break, please take it. Alyssa asked here, particularly to Mylynda and Alex, again, if there are specific things that NIMAC could do to grab the interest, engage, and collaborate with family medicine and the primary care community.
Alex, on that one?
Sure.
I'm sorry, I didn't hear what you said.
Do you want to share any thoughts on that, or?
I'm not sure exactly. There's nothing specific that's coming to me on that one. I'm not exactly sure the type of services that can be offered. It sounds like a great idea, but I can't comment on the specifics of that.
Mylynda?
Yeah, I'm wondering if we could just start with an interest group, right? That connects and shares discussion and ideas and possibly meets occasionally to think about how do we scale and expand this type of collaborative effort.
Yeah, I'll just offer up, there's another comment in the chat about genetic nurses, and some of you may know we've had some interest in the nursing school, had a planning curriculum, community of practice. Nursing school at Maryland was involved in some of the community places. The challenge right now, and we had somebody talking yesterday in West Virginia, that the paying for that training and certification, which can involve multiple years of working with clinics. So one thing we do is try to be open to having DNPs and advanced practice nurses rotate through genetics, and if they are particularly interested in specific conditions, support them through community of practice in the nursing school that has other people in it. Between Erica, Alyssa, and I'm not getting more phone calls here. I'm looking at my phone. I don't have any urgent message. Raylyn, did you want to say anything? And then I'm willing to told we need to.
I just wanted to comment on a couple of things in the chat because I think that there are really good ideas here. Is to, Jessica mentioned to use genetic nurses in genetics as an option, and so utilizing all of our healthcare providers in creative ways. That it doesn't just have to be an MD/DO that's overseeing these things. Again, pushing interest. And then somebody commented on creating a complex care rotation within pediatric residency, which Joanne, is near and dear to our hearts, is training the next generation, right? And so I think from a NIMAC perspective, to approach some of these educational bodies on, incorporating genetics training within training programs for other subspecialists. I think they would be very well received by trainees. That's what we've demonstrated and are important.
So I think I've now broken all rules here, but that's okay. So there are lots of other things that suggest connections here. So for people who are particularly interested in any of the topics that have been addressed here, there's a suggestion also about telehealth issues. And again, that's something that we have session later. So maybe I'll ask Alyssa to make sure that, we come back to this part of the conversation in that. Erica, what happens to people who break rules?
We all support them, Joanne.
I see. All right. Well,
their judgment in the moment.
All right. Well, I really think this has been a wonderful session. I'm sorry for whatever technical glitches occurred for people, but let's keep these conversations going and all. And I think people now have a 2-minute break. And then next comes the collaboration. Is that not correct?
Yes, that is right. And I'll go ahead and put a sneak preview in chat of these are the vendors.